Okay, perfect. I'm doing screen share because the PDF option half the time when I do virtual classes, it's just a white screen. So I'm glad it works. All right, as soon as the last two stragglers join, we will get started. All right, so it looks like we're still down to find out. We'll work with the class lead to get them on. We'll go ahead and get started. So, welcome to endocrinology. I am Lieutenant Colonel Gloria Heater. I am bummed we're not meeting in person, especially for the first lecture. I love working from home when I can, but I am not a fan of working or of teaching virtually, but we'll make it work. Just a few things. There are portions of today's lecture that will involve interaction. So I'm going to have you guys use the chat box when we get to that. That's for the lab at the end. And then I'm used to teaching in clinic, so I do ask a lot of questions. So I will pause for some questions, and if you are daring enough to attempt to answer, please use the public chat box to do that. For this lecture, there's only a couple multiple choice questions that we'll do as a group. So I will put a poll up for that. So watch for the poll, and if you're somebody who doesn't necessarily like to raise their hand or yell out their A, B, or C answer because they are afraid to get it wrong, you don't have to worry about that virtually because it's anonymous. So please participate in that as well, because that'll keep me moving and keep the course moving too. All right, so endocrinology. Usually I do start with some trivia. However, we can't do the trivia virtually. It's just not as much fun because I won't be able to hear the wrong answers or the funny answers, smartest answers that you guys give. So we're going to skip that for now and just jump into it. So, gosh, what's going on here? Oh man, enter. Okay, there we go. Screen changing, perfect. So we're going to skip the trivia and just a quick intro on me. I'll make this fast again because first of all, I'm from Colorado. Went to undergrad in Colorado, and I went to PA school at the University of Colorado. And I graduated in 2009. The program I went to was a little bit longer because it had an additional emphasis in pediatrics. So you'll see on the next slide, I've worked in pediatrics as well as primary care. It also had an emphasis in underserved medicine and rural care, which I do miss from time to time. I graduated in 2009, like I said, and the Air Force was not part of my plan. I had a job lined up, and then my now husband, at the time we were dating, was like, "Hey, I'm gonna go talk to this recruiter. You should come with me." And 16 years later, here we are. And he actually didn't join, and yeah, but this is all his fault. But you can see him in pictures there. We have two kids, both boys, 10 and 12, and then two dogs. We like to do a lot of stuff outside, and my weekends are typically full with sports, a lot of soccer, and they wrestle as well too. This is just a quick summary of my career in the Air Force. We have really awesome bases, and I have been fortunate enough to go to really great places throughout my entire career. Most of it has been family health, different leadership roles in the clinic. When I was at Ramstein, I worked at the wing for a year. We went back home to Colorado. I was in family health and pediatrics there. I also did a 9-month deployment with Red Horse. I had to do a variety of things with them and go all over the country, or all over a lot of countries, excuse me. And then my last duty assignment was at Eglin, and I was the Phase 2 site program director. So I know a lot about Phase 2. So if you ever have questions, just let me know. In the Air Force, they call additional duties. They call them opportunities. So I guess I got the opportunity to be the deputy commander of a squadron. I think a squadron is equivalent to a battalion in the Army. But anyway, so I got that opportunity my last year at Eglin. And despite the fun that was, I knew I wanted to stay in education. So I came to Phase 1 last summer. I've been here about a year. My course changed quite a few times. I kind of lost count. But as of the end of December last year, I got endocrinology. So this is my second time teaching it. And it went really well last semester. I'm excited to work out some kinks and teach you guys. I hope you enjoy it. I am the Air Force SSR too. Enough about me. There's my phone number. Text is probably the best way to reach me if you have questions or need to set up any additional exam prep time. My email is there as well, and then of course we have Canvas. So references for Indo are listed there. Most of the bulk of the material that I teach is from Current. If you're on Canvas, you can see I list all of the chapters, but you are not expected to read them. If you want, you can. I would say, like, if you have a topic that isn't quite clicking for you, use the text to maybe help clarify things for you. Current, super straightforward, but Goldman is going to get more into the weeds, but you have those options and I organized it for you. But for the most part, use the slides, ask me questions, and you'll be good to go. So, endocrinology. Endocrine all comes back to homeostasis, right? And the body's, goal is to maintain homeostasis. And when it comes to endo and how I teach, is if you understand what happens normally, it's going to help you recognize diseases. So my goal is that's less memorization and more just like understanding normal to help you understand diseases. And you'll see what I mean throughout this course. Enter. Okay, so goals for the semester, clinicals, and in life as a PA. So endo, when patients come in with endocrine issues, it's not typically just one symptom, right? In ortho, they might point to their elbow and say, I have elbow pain. But in endo, it's not like that. It's a cluster of things. And so through this course, you're going to be able to identify from a good history and physical exam this certain endocrine disorder. Now, endo has a lot of weird labs. I'm sorry. I will do my best to break them down and simplify them for you. But through this course, you'll know what labs to order and how to interpret them. Same with RADs. There's not a ton of radiology in endo, and don't worry. I will not, on the test, put up an MRI of a brain and say, what is this? I will not do that to you because I do not have to do that as a PA, so I will not require you guys to do that. But you will need to know what and when to order it, okay? And I'll make that super clear for you. And then, of course, treatment. You're about to be PAs, and part of that is we treat. And so understanding what treatment, and then, of course, when to refer as far as, because there's a lot of this stuff that we need to refer to endo. Okay. All right, block breakdown. So we're in block 1. This is a 2-block course, which means only 2 exams. So I'll kind of talk about how to be successful for those exams in the next slide, and then whenever we do meet in person, I'll foot stomp that again too. But our first block here is listed. I would say last semester, and then talking to Karen Sawyers, who taught this before, typically you guys do better on the second exam than the first. And I think that's because the material in the second block is just easier to digest, and it's less like you're less likely to get it confused. But I'm confident we'll make block one. It'll come together for you guys. So today we are going to get through the intro, which is really fast, and posterior pituitary, so lesson 1 and lesson 2. At the end of each block, there's 2 courses or class times left where we'll do an exam review and a lab. Last time I got through the material quicker than the previous instructor, and anticipate that will happen again. So I will most likely give you guys some time back to use for capstone research and studying, but of course I'll work with your class lead on that. Okay. All right, so testing procedures. So usually I ask this question out loud, so if anybody's brave enough to put something in the chat, what do you think, what's a subclinical case? What is that? Yeah, Aaron's typing. Yes. So yeah, doesn't meet diagnostic criteria, doesn't present normally. Exactly. So in life, especially with endocrinology, there are so many times where the patient's lab and their symptoms don't match up. And there are slides in endocrinology where I specifically talk about subclinical, but I'm not going to test you on that, okay? If I have a low thyroid patient, their labs are going to match what a low thyroid patient will, or a hypothyroid patient will be. I won't do that to you. However, it's so important for you to at least be aware that subclinical cases exist, specifically with hypothyroidism and low T, so hypogonadism. So I added those to your slide deck, but I won't text you on it, okay? As far as the normal lab values and ranges, I am going to provide those for you on the test the vast majority of the time. There in block 2, there is, for diabetes, I want you to know the ranges, but I will tell you that. And if I want you to know it, it means I'm going to teach it a few times, okay? So you won't be surprised. But again, I'll either give you the ranges or I'll tell you it's high or low. Fair enough. I already told you about radiology. I'm not going to quiz you on that. And then obviously I need you to know basic abbreviations, which you guys by this point you already do. So I'm going to take just a quick second to foot stomp how to be successful in this course as far as testing, and then again I'll do it more in person. But I highly recommend you guys pay attention in the courses. I know you're halfway through your junior semester and you guys all have your own individual study habits and a flow of how you prepare for each exam. And that means that there are some of you who study during POI time. I technically can't control what you're looking at on your computer when I teach, but I highly recommend, at least for endo, that you pay attention during the course. And that is because endocrinology is hard. It's tricky even as I try to simplify the different diseases. It can be confusing when it comes to exams. So if you pay attention while I'm teaching, and then when it comes time to studying, it's not the first time you've been exposed to this complicated material. And as adults, we learn best by repetition, right? So again, just the goal, if you listen now, it will help you for the exam. And knowing that adults learn by repetition, I intentionally repeat certain things and I foot stomp certain things. A lot of times you'll see on my slides, I put FYI, and so I'm not trying to trick you on what you need to know and what you can, not focus on for the test. But sometimes when I teach, I'll also say that too. So if you're paying attention, you'll get that. The first, I think actually both exams are on a Monday, which means you have like the weekend to study for block one exam, which is again harder of the two. So again, I really encourage you to listen so that you're more successful. And then of course you can, it'll help you with your questions, right? If you have questions real time, getting the answers to that right away, I think is more beneficial. Okay, so the end of my testing soapbox. All right, next slide. Okay, so NCCK said the PANCE, right? So in chronology, it was 7%, now it's 6% of the PANCE, which is roughly about 21 or so questions, 21 or more. And then if we look at the breakdown and even further, this is, I use this to guide the syllabus and what we talk about. So you can see all those topics there. And the little white numbers on the left side correspond to the lesson, okay? And then you can see on the lower right, gastroenterology, obesity falls under GI, but Endo takes it, and it goes really well with diabetes. So these are all the fun stuff we're going to learn about. All right, so here we're going to start a quick poll. I know you guys have had first order, second order, and third order questions by now, but I just want to kind of introduce what an endocrinology test will look like. So the poll is posted. All right, so first order, which of the following hormone is secreted by the adrenal cortex? Give me a second to read that. And I really realize you guys learned about this a long time ago. And you're probably focused on ortho right now, so that's on Friday. We'll see how you do. Okay, awesome. I have the majority of results are in, and so I'll give you the answer. Does it let me give you the answer? Okay, I just have to publish the results and answer. Oh, Lord. There we go, cortisol. Good job, most of you got that right. Don't worry, we are going to talk all about cortisol a bunch of times. All right, so moving on to a second order question. This is, again, Endo gets a little dicey, so let me add a poll real quick, and then I'll read it for the person who's recording this. Okay, and start poll. Okay, so we have a 32-year-old male patient complains of a 40-pound weight gain, symmetrical joint pain, and increasing fatigue for the past 3 years. His boot size has changed by 2 sizes during this period. On exam, he's hypertensive, and his weight increase is confirmed. You note an enlarged forehead, palmar hyperhidrosis. Again, if we were in person, I would ask what that is, and that's just like excess sweating, right? And proganthosm. That one is where the jaw is protruded and enlarged forward. Which of the following conditions is most likely the diagnosis? So again, just this slide kind of highlights and breaks it down. In Endo, the age and gender a lot of times is intentional, and it's to help you. And again, there's a lot to this, right? But yeah, the good history and a good physical exam should hopefully get you to the right answer. We had a lot of responses, so we're going to go ahead and publish it. You guys did great. Acromegaly is the condition. Good job. And then the next one, sorry. Okay, next one. I'm not going to read all of it because it's basically the same exact scenario, but third order question. So when you look at what we're asking is which of the following is the best initial lab test to order for this condition? So, you know, it's acromegaly. This is, just give this one a try. And this is, oh, look at you guys. Good job. This one, you will know the answer to this by the end of lesson 3. Thank you for participating. Okay, so we kind of have a mixed bag on this one, and the actual answer is E, insulin-like growth hormone factor. We'll explain why growth hormone lab isn't ideal for acromegaly. And so it's better to practice and learn during a lesson like this than on the test. So, all right, good job. Thank you again for participating, you guys. Okay, so this is just a kind of a table that I left in here just to kind of reiterate that endocrine is kind of like solving a puzzle, right? And the patients don't come in and say, I have a prolactinoma. No, instead they come in with amenorrhea or a headache. And then they don't come in and say, I think I have a pheo. Instead, they're coming in with anxiety and palpitations, right? So it's a constellation of symptoms that get you to the right diagnosis. And this being said, fatigue, the vast majority of these patients struggle from fatigue. So there's no way I can ask you a question where I just say, a 32-year-old female complains of fatigue. What does she have? I can't do that to you, right? So I have to use a constellation of symptoms to help get you to the right answer. Okay, so I'll be fair, I promise. The next one. There we go. Same with physical exams. It's a puzzle, right? It's multiple things, or sometimes they have nothing wrong and their exam is normal. So you can lean on labs and stuff. But again, it's a puzzle, a fun puzzle, and helpful for your patients to solve. And then we no longer talk about primary ovarian failure or Turner syndrome. Okay. Again, I mentioned earlier FYI, so I do try to label the slides for you so that you know it's either like for your information, for your situational awareness, or maybe for your like future clinical awareness. But endocrine crosses over a lot with clinical correlations. I know you guys haven't really had very many ClinCore labs yet, but in my group, I really, because we do OSCEs in phase 2, so this is one of my favorite classes to teach. But in my group, I hit, if you get a good history and a solid physical exam, you'll figure out the diagnosis for ClinCore. And that's the same with endo. A good history, a good physical exam will point you in the right direction. Of course, though, in clinic, you need to listen to your patients. And even if you have someone come in with some weird stuff going on and you're like, I have no idea what is happening with this patient, but if you listen and don't dismiss them and say, I'm going to work things up, we're probably not going to solve this today, it'll go a long way. And then obviously the medical knowledge you're going to learn in this course will help build your differential and your treatment. Make sense? I hope you got heads nodding. Okay, next slide. All right, so now we are starting the intro to endo objectives. Thank you. And these are the things we're going to talk about. I have a feeling we will wrap this up probably in 15-ish minutes. So, and then jump right into the second one. Okay, so think of the endocrine system as a collection of cells and glands that produce and release hormones. Okay? Hormones are the bread and butter of endo, and these hormones regulate many things, as you can see: growth, reproduction, development, even plays a role with electrolytes and water balance in the body. So it's super important. I left this slide in here because it might help some of you understand how because you've already learned in neuro various things about how the nervous system works, and there's overlap with endo as well. So when we think back many weeks ago to the beginning of neuro, the communication for the nervous system is neurotransmitters, right? And they're released in a synapse, which is actually really close to each other. And from that synapse, that message goes to the target cell, which is maybe a muscle cell or a gland or something else. And in the nervous system, this communication happens really, really fast. And for the most part, it doesn't last super long. So again, an example would be like, you touch something hot and the neurotransmitters communicate down and they do their magic, and I know that this is hot and I pull my hand away, right? So with endo, we said there's some similarities, but gosh, not too far. But instead of neurotransmitters, it's hormones that regulate things, right? And and instead of released into a synapse, these hormones are released into the bloodstream, and they typically go to a location farther away from where they started. So from the pituitary gland in the brain, hormones released through the bloodstream and goes to the target organ, which is, say, the thyroid or the adrenal glands. Okay. Um, we're going to talk about ADH today, and that happens really fast. But a lot of the hormones doesn't happen really fast, and when the hormones are released, usually the impact is much longer than the nervous system. But again, if that helps you, there you go. Okay, this is absolutely review, super easy concept that you learned in Path and Fluid Lab and all those things. But hormones can circulate freely or bound. And that free form is that biologically active form. So this, though, I do want to spend a couple minutes on, and I want you to understand, so start the slide, the different hormone classes. So on the left, you have lipid insoluble. These are those large polypeptides and proteins that can't pass through the cell membrane. Right, and so they interact with receptors on the cell, and then that causes a cascade of events to get that target cell to do what they want them to do. On the other end, we have there we go, all things. On the other end, we have steroids and thyroids. Okay, so these are your lipid soluble; they're much smaller. Therefore, they can pass directly into the cell membrane and go communicate with the nucleus to produce the changes, right? But these guys do need to be chaperoned through circulation, right? So they're binding proteins. We talk mostly about the binding protein in block 2 with testosterone, so we'll kind of tie back to this in block 2. Now, if you look at the bottom, you have your examples. And if you compare the two, it's not that hard you don't really have to memorize a whole list, right? So if you look under steroid and thyroids, the examples are your thyroglobulins, right? Your T4 and T3, and then all your testosterone, progesterone, aldosterone, cortisol, and then everything else is a polypeptide and protein, right? So hopefully it doesn't make you feel like you have to memorize it, and it's kind of common sense. Okay. Pause for questions. Okay. All right. So this is something I need you guys to know, and I know it's something you learned already. I think your freshman semester and in pathology. All right. So the negative feedback is key to endo. We're going to talk about this all the time. So if you ever get tripped up, or one of the negative feedback systems isn't clicking for you, come and talk to me, okay? And remember, the goal for endo is to maintain homeostasis. So when it's disrupted, like let's say there's high levels of circulating hormone, the endocrine system will decrease hormone synthesis and secretion. Same in the opposite, okay? So if the disruption is low hormones, we're going to use negative feedback to increase hormone synthesis. So the example there is written out for those of you who learn that way, but to me, I think this is better. So we have our diagram here, and we're going to focus on the pituitary gland, not so much the hypothalamus. You're welcome. Okay, it's all going to be mainly pituitary gland. All right, so we're talking about thyroid hormone, and function is homeostasis, but it's disrupted, and so there's a decrease in hormone. So that decrease in T4 and T3 tell the pituitary gland, like, hey, T4 and T3 are low, so the anterior pituitary gland releases TSH, thyroid stimulating hormone, and it does exactly what it says it's going to do, and it stimulates the thyroid gland to produce hormone. Love that. So again, it's released through the pituitary, through the bloodstream, goes directly to the target gland, it's the thyroid, and then the thyroid gland does what it's told. Yes, sir, yes, ma'am. I'm going to produce more T4 and T3, and then we have homeostasis is restored. Okay, very, very quick review of this. and we'll talk about it off and on throughout the course, okay? So positive feedback is the exact opposite. Cool. In endo, we don't care about it. It is important in life. Oxytocin is very important, but for endocrine, we don't care about it. Again, positive feedback, it's important, but that's for next semester. Okay. So the overall take on this. So this talks about there's other mechanisms and systems to help maintain homeostasis outside of just negative feedback loop, okay? And it's specifically related to receptor availability and ultimately tissue response. So let's go back to that scenario where we said the hormones were depleted. There wasn't enough T4 and T3, so the negative feedback loop is activated. But in addition to that, receptors pick up on that and they're upregulated, so it increases availability. Okay, so then the goal with that is to increase target tissue response when there's a decreased hormone. Again, this isn't something you have to memorize, just understand the overall take home is that we have other ways, the body has other ways to maintain homeostasis. This one I do want you to know and understand these terms because they are going to come up over and over and over again, and they're also in the disease names themselves. So primary alteration is one regarding the hormone secreting gland. So hyperfunction. So we're dealing with hyperfunction. What do you think when I say there's a primary hyperfunction of the thyroid? What do you think is going on? So, Graves, yes, so it's Graves. So where's the problem? Is the problem in the thyroid gland or the pituitary? Yes, thyroid gland. So yes, so all you have to remember is primary is the gland. So if it's adrenals, and it's a primary adrenal insufficiency, then the problem is in the adrenals, okay? Secondary is always going to be pituitary or hypothalamus. For this class, it's pituitary. So if I have a secondary adrenal insufficiency, then boom, the problem is in the pituitary gland, okay? So again, this will come up over and over again, and we'll pause and make sure that nobody's confused. So again, secondary pituitary, primary is that actual gland, secreting gland. And then the word ectopic should not be new to you guys, but this is when hormone is secreted from another tissue, from a different source, typically like cancer cells, right? We'll talk about that a couple times throughout endo. And then this one is that we talked about hyperfunction on the last slide. This is hypo. The same thing stands. Primary is the gland itself. Secondary is pituitary. But instead of ectopic, there's resistance. And we're going to talk about resistance today with ADH in the kidney. And that's just the hormone's there, right? But there's that target tissue can't recognize the hormone, so then it can't function, can't do its job, right? So we'll talk about that only today. This is the last slide of lesson 1. It just goes over some terms that I use a lot. So adenoma, you should know what that is. I think you guys all do. It's benign enlargement, glandular secreting cells, right? It can become malignant, but typically it doesn't. Neoplasm, obviously you guys know what that is. Hyperplasia and atrophy. Okay, so just terms we're going to use a lot, so you need to understand them. Refresh your memory on them, okay? All right, so that's it for lecture 1. Typically you guys don't have any questions on this, so I'm just going to jump into lesson 2. If I started at 10:05, I'll try to shoot for the break around 10:55 if that works for you. Let me just change my slides. Okay. Thumbs up. Can you guys see that okay? Yes. Yay. Okay, perfect. Tell you when PDFs hate me in here, but the screen share is working, so I'm happy. Okay. All right, so posterior pituitary gland. We should get through this today. Okay. We will start with a very quick review, anatomy review. It's quick intentionally, so that means I'm not gonna quiz you on the anatomy, right? You guys have already done that, but just to get you on the right mindset, let's talk about it together. So here's the lovely pituitary gland located in the sella turcica. We have the anterior and the front, and that is a true gland. Oh, can you record? Oh yeah, I'm sorry. Start recording. Yes. Okay. Okay, it's recording. Okay, so again, posterior pituitary, sella turcica. So the anterior pituitary, we're going to talk about a lot tomorrow. And then you have the posterior pituitary behind. So it's the posterior pituitary technically isn't a gland. It's an extension of the distal axon terminals from the hypothalamic neurons. And there's another picture which will show you that. Now, I'm not going to quiz you on that, but it's just something to understand. But again, most of the pituitary's action is in the anterior section. Okay. All right, so again, this shows the comparison of the two. And when we look at the posterior side on the left, we have two hormones that are involved, oxytocin and ADH. And if I already said I don't care about oxytocin and its lovely positive feedback loop, then it should be no surprise that we're not going to talk about it at all. And we're only going to talk about ADH in this lecture, which is antidiuretic hormone. Okay, so only one you need to know. And you can see in the picture again how I mentioned it's an extension of the neurons from the hypothalamus. Kind of displays that. All right. And then, of course, you look here on the right, and that's all the fun stuff we get to talk about later. Okay, so another name for the posterior pituitary gland is your neurohypophysis. I'm just going to call it posterior pituitary, but for your awareness in literature, it has two names. I already mentioned it's not a gland. Technically, so ADH and oxytocin is actually synthesized in the hypothalamus, and it's just stored in the posterior pituitary gland. So, and the storage, the fact that it's stored there and ready to be released is really important when we talk about ADH, because when we need that antidiuretic hormone, we need it right away. And so, again, it's stored there and released when triggered. Okay? Do I care about oxytocin? No, I only care about ADH. Man, wish we were in person. It's okay. All right. Next, we are moving away from that very, very quick anatomy review and going into normal function of ADH or antidiuretic hormone. Okay, and again, if you understand what happens normally, it's going to help you figure out abnormal much easier. Okay? All right, so ADH has a couple names, of course. I just am going to call it ADH to be consistent, but also it's vasopressin. And it, I think you guys already know this, but vasopressin acts on two receptors. You have V1 and V2. V1 is related to vasoconstriction. So what is an emergent situation where the body would need to vasoconstrict and where it would need a pressor, even though, as you can see, I say ADH is a weak pressor. But what's the scenario? Type of hypovolemic. Yes, perfect. You guys are great. Shock, hypovolemic, blood loss. Exactly. Sepsis. That's when we're going to need it. So thankfully, the body has much stronger pressors that you learned about probably with Dr. DeBoer. But we have ADH plays a role of that as well. But what I care about more is what happens in the V2 receptors. And that is in the nephron, specifically the collecting duct of the kidney. And when you think of ADH, it's in its name, right? Antidiuretic means what? It stops diuresis. So it's that water retention hormone, right? And the function of ADH is to retain water in the body. So if we're retaining water in the body, what happens to urine? It's going to decrease, as you can see in there. So again, that's the kind of the main function of ADH. And because of that, it plays a key role in water balance homeostasis, specifically related to serum osmolality. So when serum osmolality increases, ADH is released. And there is coordination with the thirst center, and we'll talk about both of those 2 points in detail as we go forward, okay? But before we do that, who has any tips on how to memorize this guy? Anybody? Yeah. I don't need you to memorize it. Don't worry. All we're going to use it here is for like a diagram to understand how ADH works in the nephron. So no memorization needed. But again, talking through this will kind of help you understand what's going on. So let's do that. So when ADH is released, it travels through the bloodstream from the posterior pituitary to the collecting ducts, to these V2 receptors. And as ADH goes up, there's an increase in these aquaphorins, which is essentially a channel that helps the body retain water. So as we retain water in the collecting ducts, ultimately we are decreasing urine loss. Okay, it's that simple. There's a lot more going on, but that's all I need you to know, okay? As far as regulators of ADH secretion, we have baroreceptors and osmoreceptors. I'm not going to be really surprised. I don't care that much about baroreceptors in this class. But just for your awareness, the baroreceptors are obviously in the arteries, and when there's a 10% or greater decrease in volume, ADH will be released, right? And that's in that hypovolemic, that shock, blood loss state. But for endo, we're focusing on osmoreceptors. So these osmoreceptors pay attention and they sense changes in osmolality. So osmolality is concentration of dissolved particles. So I have sodium bolded for a reason, but just so you know, it's not just sodium. There's other particles that make up osmolality. But so these osmoreceptors, when they sense a change in that level, it's going to release ADH. And I think this is really cool. So a 1 to 2% increase in plasma osmolality releases ADH. So not, it's a small percentage in change. And again, so if we're talking increase in osmolality, that means there's an increase in those dissolved particles, right? It's more concentrated. So the body wants to increase the total water absorption to maintain that homeostasis. I'll talk about that a couple times with the slides, so you guys, it'll click if it hasn't already. Real quick, that 1 to 2% increase, I mentioned before that the posterior pituitary, these hormones are just stored in there, right? So they're stored. So when there's just this tiny, tiny, small change in osmolality, ADH can go out quick. And then obviously same in a stroke situation or hypovolemic situation. ADH stimulation, so kind of already alluded to this. So elevated serum solute, so that specifically sodium concentrations, which cause the hyperosmolality state, will release ADH. Hypovolemia, hypotension, and then medication. There are a lot of meds that mess with ADH regulation, and we'll talk about what you need to know for the exam, okay? And on the opposite end, we have inhibition. So it's the exact low serum sodium or concentrations. We're going to decrease ADH secretion. And the same makes sense with the high or normal blood pressure, right? And then alcohol is another inhibitor. What does alcohol do when you drink when you have a few drinks? What happens to your it juices, right? It makes you pee. I don't know. When I was young, they called it break the seal. I don't know if that's still a term, but yes, you drink alcohol and it's a diuretic, and it actually inhibits the release of ADH, and so therefore you pee a lot. But we know that alcohol dehydrates you, so you're peeing a lot, and even though you're drinking fluids, you're not actually hydrating, so you have risk of dehydration because of this. All right, so here is your lovely plasma osmolality calculation that you do not have to memorize, okay? But again, like I mentioned, I focus on sodium a lot, but it's not just sodium. Obviously, glucose and BUN play a role in getting to that osmolality level. The normal range is right there. And again, for the test, I'm going to either tell you it's 300, and I'll put the range, or I'll most likely say it's elevated, okay? And just before we continue, I'm going to ask this question to the group. When serum osmolality increases, what does ADH do? So increased osmolality means an increase in sodium, and so yes, exactly, it increases, it's secreted, right? So we have this concentrated serum, and we want to dilute it a little bit to reach homeostasis. Perfect. All right, here's just like a nice, pretty summary. This is how your brain works better. Again, if you can see my mouse, hopefully, pituitary gland, hyperosmolar state releases ADH and goes to the kidney. Okay, and this is right here. This is what I care about, and I care about what happens to the urine. All right. So that's it for the first half of lecture. We can go ahead and take a break now, and then I guess come back at 11:03. Again, if you guys have questions after the end of this lecture, when we're going to go through the two disorders, typically you come at the break. So please, you can text me or put something in the chat, or hopefully whenever we get back face to face, you can ask me those questions too, okay? I know it's harder to do that in this virtual platform. All right, so we understand all the background about normal ADH, posterior pituitary feedback, where it works in the kidneys and all that good stuff. So now we're going to move straight into the disorders. And again, we're focusing on those osmoreceptors, the V2 receptors in the collecting duct of the kidney, not the baroreceptors. All these are very important, not for this class. Okay. Here we go. All right, talking about that. Okay, so we have two different disorders related to ADH, and you can see, so one is syndrome of inappropriate antidiuretic hormone, which is why we call that SIADH, and diabetes insipidus. So SIADH deals with too much ADH, and diabetes insipidus, the exact opposite, where you have not enough. To help determine which condition, key things to pay attention to regarding the patient's complaint is urine production, thirst. Thirst plays more of a role in diabetes insipidus, and then looking at the labs. So I know we haven't actually talked about SIADH, but what we know about ADH itself and what releases it, if we have too much ADH produced, what do you think is going to happen to urine production? Is it going to have too much urine or too little urine? Go ahead and put that in the chat box. So too much ADH. Too little, exactly. So we're gonna have too little urine because the body is absorbing, increasing its total water amount, right? And so ultimately we have decreased urine, and that urine is super concentrated, right? It's dark, it's concentrated, and so well, that's what the labs will tell us. And obviously, for diabetes insipidus, it's the exact opposite. It's very easy. Trying to keep it simple. Okay, let's talk specifically about SIADH. All right, so we know that ADH is stimulated by hyperosmolality, right? However, in this situation, the excess secretion of ADH is not due to any osmotic stimulus. It's inappropriate ADH secretion, and it's in the name. So think SIADH, think it's like inappropriately released ADH. Nothing is triggering it. Nothing wants the excess ADH. It's just being inappropriate, doing its own thing. And then again, thankfully, it's actually in the name, right? So, any questions about that? So again, the normal things that stimulate ADH are not into play. Inappropriate all the way. So here is a chart from Current, and it lists all the causes related to SIADH. And I'll be honest with you guys, some of these causes we understand why, and some we don't. We don't know why it happens, but it does. And a lot of times when SIADH happens, typically it's short-lived and mild, but there's cases when it's not. So it's important to understand this condition. Okay, so and I promise you don't need to know everything. I highlighted the stuff we're going to talk about. Okay, so etiology is related to CNS disorders. So you have a list there, and this makes sense. So if you have a stroke, infection, or trauma, it's going to impact the release. Possibly it's impacting osmoreceptors, but it's going to mess up ADH, and it's inappropriately secreted. So CNS disorders, I'm not going to make you memorize all of this. It's just no CNS disorder, SIADH. Pulmonary diseases, to me, this doesn't make sense, and we don't really understand why a lung infection can trigger SIADH, and it's not. It could be any one of these three. It could be viral, bacterial, but for whatever reason, lung infections can cause SIADH, and typically it's temporary or mild. Then we have malignancies. I think this one makes the most sense. So because malignancies and tumors are inappropriate by nature, right? They're the ectopic release of, they're ectopically secreting all sorts of things. So, so we have these cancer cells that produce and release too much ADH. And again, this is an ectopic malfunction. And you have a long list of cancers, but all I care about is the small cell lung cancer. And the reason is because it accounts for 80%. That's pretty significant. 80% of lung tumors are associated with SIADH. So that's what I want you to focus on. Now, let's say you're in clinic, you're in phase 2, or you're a PA 2 years from now, and you have a patient who comes in and they feel fine. They're there for their physical. But you get labs, you take a good history, and you notice they report a decrease in urine output, they have this concentrated urine, and their sodium is low, and maybe they don't smoke now, but they smoked for a really long time, and they just recently quit. That should spark things off for SIADH and cancer. So you'd want to definitely order a CT for patients that have unexplained hyponatremia and low urine output, especially if they have a history of smoking. Okay, that one is something you probably could see as a PA. Okay? And then medications, of course, medications. So let's talk about a few of these. So because again, there's a lot more meds that can cause an increase in ADH. Some of this you might have talked about in pharmacology, so we'll go through it and then I'll tell you what I want you to pay attention to. So SSRIs, antidepressants, they can cause SIADH specifically in your elderly patients, so over 65. Cancer meds, anticonvulsants can also mess with that. MDMA, what is that? I guess I won't wait. I'll just tell you. So it's ecstasy, right? So this is not common in our patient population, but you still can see a dependent or even an active duty member who takes MDMA. And so the problem with that is that it's stimulating the secretion of ADH inappropriately, but it also causes a dry mouth, and so patients will have an increase in thirst. And so you have excess ADH and excess thirst together, and it further dilutes the body, and so you potentially have significant hyponatremia. So not good. NSAIDs can also affect ADH secretion, opioids, and antibiotics. So I don't need you to memorize all of these things. What I'm going to do is we've talked about etiologies from CNS disorders, pulmonary infections, infections, can't talk, malignancies, specifically small cell cancer, meds, and then I'll talk about other causes. So we have all of these things. I won't just put one. I won't be like, all right, you have a 65-year-old female on antidepressants. What do you have, right? No, it might be a 65-year-old female because we know that antidepressants cause SIADH in the elderly population, and they have a history of lung cancer, or maybe they have a history of smoking, and they just had surgery. So again, I'm going to tie multiple etiologies, not too tricky, right? Because I don't expect you to memorize all of this, especially with all the material that's in Intel. Does that make sense? Don't memorize everything, but just like it's a piece of the puzzle to get you to the answer when I give you an exam question. Okay, good. Then we look at other causes. The one I have underlined is post-op state, because that's honestly most of the time you're going to see SIADH. Especially because it's really mild and patients don't actually even know that they have anything going on. But when you're post-op, a lot of times you're monitoring electrolytes and things like that, so you'll catch it. Okay? So don't stress out about the etiologies. Have an overall understanding of all of these. Okay? All right, any questions? Okay, so clinical presentation. So we have acute versus chronic. There's very definitive time frames for acute and chronic. So acute is less than 48 hours, and chronic is obviously over 48 hours. Of the two, chronic is much more common, and so you'll likely see that. So when we're talking about acute, you guys have hopefully heard the term sick, not sick, and not sick when you open the door, you're going to see a patient, you open the door, and you can just tell they're sick, right? They're off. You'll have people who say they're sick, but they're talking to you, walking around just fine. But these patients are typically very sick, and they stand out that they're sick. And that's because of the brain swelling. They could have a severe headache, decreased attentiveness, so they're a lot of times disoriented, or confused. Vomiting, nausea goes along with this, even coma or death. So again, typically your acute, less than 48 hours SIADH are significantly sick. Now, you can have people in this window who have mild symptoms, but I just want you to pay attention to acute and severe. Okay? Moving on to chronic, the most common cause of SIADH. It's interesting. So these days, the body has adapted to this low sodium state, right? This diluted osmolality state. And so a lot of times they feel fine. And if you ask them direct questions, you might get like, oh, I have some concentration. I'm having some concentration issues or gait balances. But a lot of times this is picked up incidentally on routine labs. There are situations where somebody who has a known SIADH and maybe they get sick or their meds change or something, and they start to become symptomatic. And I'll talk to you about what to do with that. Okay. Remember I talked to you guys at the beginning when you're trying to decide is this SIADH or DI. You're going to look at the urine production and the labs. So we're going to do that again. Obviously, we already know urine production of SIADH is going to be decreased. Okay. I say this, I think, in another slide too, but signs and symptoms, so this are in treatment of SIADH are tied to knowing that the low sodium is a result of excess water, not a deficiency in sodium. Okay, I think that makes sense because we've already we talked about that a lot when we introduced ADH. But again, these people who have this headache, this lethargy, this seizures, is because of the excess water. Okay. We need to know that when it comes to treatment. Okay, let's look at the lab. So, say that. Okay, so, sorry, I'm struggling on the screen here. Bear with me, guys. Okay, so labs, we want to look at the sodium. So we're going to do a CMP or BMP to get the sodium. So this makes sense, right? So as ADH, too much inappropriate ADH release, we're going to have a low sodium, hyponatremia, okay? And the reason why is because there's an increase in total body water, which just through dilution lowers the sodium, right? And then again, remember it's inappropriate release, okay? This section here, I put the ranges of normal serum sodium. You don't need to memorize the classifications. It's just more for your awareness when you get into clinic. That typically the severity of symptoms are related to how low the sodium is. Not everybody. Especially with SIADH in the acute phase, you could have somebody with maybe like sodium of 128 and they look horrible. So again, this is more just FYI, and I will give you the range. But what I need you to know is SIADH, sodium is low, hyponatremia. You can't have SIADH without hyponatremia, okay? There's additional labs that you may order and you'll see, but I don't care about that for the test. This is what I care about, hyponatremia. And you guys understand why. In addition to that, you're going to have a decreased plasma serum osmolality, right? It's going to be low. Again, if you're confused at all about that, go back to the last slide. It's because of the increase in total water body, okay? And again, so decreased osmolality because of dilution. And then when we look at the urine, this should be no surprise. If we're holding on to water, we're decreasing our urine output, right? So we have very concentrated urine, so we're going to have high urine sodium, high urine osmolality, and then high specific gravity. So it's what, if you look at this person's urine, even without testing it, what color is it going to be? It's going to be really dark, really concentrated, okay? So hopefully all of that makes sense. So we don't actually measure ADH, and that's because the the urine osmolality is a good surrogate, and it tells us what ADH is doing in the body. So again, all I care about for this is low sodium, so hyponatremic, decreased osmolality. Both of those are because of the same reason, and then of course urine is going to be concentrated. Okay. So current lists clinical diagnostic factors or for SIADH, and then listed below. I think all of this makes sense. So hyponatremia, said that like about 5 times already. Decreased osmolality, again, due to the same excess ADH dilutes the total body water. And then high urine osmolality, high urine sodium, right, that concentrated. And again, all of this is in the absence of other conditions, right? So they're not having something else going on. So in clinic, you need to rule out those heart disease, kidney disease, all of that. On your endo exam, I'm going to make it clear as day. I'm going to tell you that you don't have chronic liver or kidney disease. Okay, I'm not going to do that to you. I'm not going to try to trick you. Does that make sense? Yes. Right, I left this slide in. I'm not going to talk about it, but it's just another, it's a table format of everything we've talked about as far as labs for SIADH. So moving on to treatment. So again, these people are appearing, they have signs and symptoms related to low sodium, but again, it's related to excess water, not deficiency. So if they're stable, we want to focus on treating the underlying cause, right? Is it a medication they're taking? Is it because they have lung cancer, so maybe oncology needs to take it, or is it post-op and we're just going to monitor them? So we all don't forget that the underlying cause is really important when dealing with SIADH. And then next we're going to consider two factors regarding treatment: acuity and severity of symptoms. Okay, let's talk about it. So first, acuity. We have an acute patient of SIADH who's had it for less than 48 hours, so we're in the acute phase, and they're severe. So when we talk about sick, not sick, this person is sick, right? Circling the drain. We are nervous. For these patients, we are going to treat quickly. We're going to treat them with hypertonic saline, okay? And we're treating them at the rate at which it failed. So this is the only time we are going to treat them quickly with hypertonic saline, all right? You can see below, there's the guidance for replacement. You need to know that. Your ER will have their own guidelines, and that stuff changes, so you don't need to know that. And then the block below, where you can have patients who have acute SIADH with mild symptoms. And for those, you don't have to replenish their fluids right away because they're talking to you, they're stable. But again, I don't care about that for the test. I just want you to know technically that exists. But we're focusing on acute and severe. We're treating quickly with hypertonic saline. Switching gears to chronic. Chronic, again, is over 48 hours, and most commonly, people with SIADH fall into this chronic window. So when we decide how we're going to treat them, we know it's chronic. Now we need to look at the symptoms. Do they have neurologic symptoms? Yes or no? So if they do, they're going to have that lethargic, they're going to be lethargic, disoriented, maybe vomiting, throwing up. They're going to appear sick. Then those patients need the hypertonic saline, but not as fast as they do for the acute. So remember, acute, I said treat quickly at the rate of which it's failed. But for chronic, someone who's had SIADH, maybe they have known SIADH, maybe it's that cancer patient who has it, or you've been monitoring them for days, you want to replace it slowly. And the reason you want to do that is because you want to avoid the locked-in syndrome, which is osmotic demyelination syndrome. And so if you treat somebody too rapidly with sodium, you can cause this. And it doesn't happen right away. It's days later, and it's often irreversible. So you're causing permanent damage, and it's like scary stuff, right? So that locked-in syndrome. So you could have dysphagia, your paresthesis, coma, death, all of that things. So again, it's much slower sodium correction. And then if you have, looking at back at the neurologic symptoms, if they have no symptoms, they're asymptomatic, or they're like maybe having some concentration issues, then you just treat them with fluid restriction and potentially some medications, okay? So hopefully the take home is acute, sick, treat rapidly. Chronic, sick, treat with saline, or treat with hypertonic saline, just not super fast. And then asymptomatic, minimal. It's restrictions and meds, okay? So here, oh man, I tried to, so I'm gonna, if you follow my mouse, you can see what I want you to know and what I don't want you to know. Okay, so at the top, severe symptomatic, we're treating, they have severe neurologic symptoms. We're gonna treat with hypertonic saline, 3%. This stuff in the middle, I don't care about, right? I don't even care about the bolus amount over 10 minutes. I just need you to know this, hypertonic saline, 3%, okay? Um, so FYI to all of this. It makes sense that you'd want to, if you're going to treat somebody with SIADH with saline, you want to go ahead and monitor their serum sodium. So again, that makes sense. So once you have successful rehydration and you fix the sodium deficiency, then you're going to look at meds and look at treating the underlying cause. But again, these patients are really sick, so your primary focus is the hypertonic saline first. Once they're stable, you're going to monitor levels and then look at the cause. Okay, so really just care about this top part because this is common sense down here. Right, so chronic hyponatremia without severe symptoms. So again, these guys are typically asymptomatic. They're coming in for a wellness visit and their CMP shows low sodium, and you talk to them and they're like, yeah, I don't pee ever, and when I do, it's really dark. So you're thinking SIADH, so you're gonna try to treat any underlying cause, and then you're gonna do fluid restriction works for these people. And so you restrict fluids 1 to 1.5 liters per day. So, and these are people with mildly low sodium. So it's kind of cool, right, when you have when a treatment doesn't involve medication, but compliance is not very great with this, right? Because we like to drink water, especially if you're an exerciser and things like that. So it would be kind of hard to keep with this 1 to 1.5 liters per day. So patients who can't keep to that, there are medication options for them. Okay. And so medication management. I'm pretty sure I looked at Pharm last semester, and I think Dr. Hart talks about this, but the primary thing you really go to is a vasopressin receptor antagonist, or the Vaptins. So Vaptins are interesting. They work in this, but they're done by infusion, and there's some limitations. So there's Contivaptin that is non-selective to V1 or V2 receptors. So a lot of times people will recommend Tolvaptan because it's specific to the V2 receptor only, but that medicine can only take for 30 days because it can cause liver toxicity. So again, Vaptins are effective, but you as a primary care PA will not be managing them. Just know that they're a treatment for people where the fluid restriction doesn't work. I don't know if you guys tell, I don't have Tolvaptan and Contivaptan in here because I don't need you to know it. Okay? Just the drug class itself is fine for my class. Loop diuretics can also help, right? So we have dark concentrated urine, and so we can use like Lasix or furosemide to help with these patients. There's a tetracycline, damoclopacine. Damoclopacine is an antibiotic that diminishes the effects of ADH. So if you have a patient while you're trying to treat the underlying cause, you could give them this tetracycline to help with it. And then SGLT2s. Have you guys talked about diabetes meds yet in Pharm? So, okay, cool. So these ones, you get diuresis through, you push out the glucose through your urine. And so this is another option for management for someone with SIADH. And then, I guess, spoiler alert, if I don't talk in detail about these specific things, and you don't need to know the detail. I just like to add it for awareness, but not for the test, okay? All right, so when to refer. You're going to refer to nephrology and possibly endo. I would just refer to both. For anybody that has severe SIH, refractory, and complicated cases. So honestly, I'm going to refer early, especially because I think fluid restriction will be really hard to maintain, and I want them in the hands of the specialists, okay? So any questions about SIH? Questions later. Okay, we're going to jump into diabetes insipidus, which is the exact opposite. So next block, in block 2, we're going to talk a lot about diabetes mellitus. Mellitus means honey and sweet, where insipidus is tasteless or not tasty. So the urine, and it's referring to urine. So the urine is, yeah, we used to taste urine back in the day, gross. We don't do that anymore. But it's tasteless because it's super dilute. And let's go into it. But yeah, just remember, diabetes mellitus and insipidus are very different diseases. You guys probably already know. All right, so again, too little ADH, which means we cannot concentrate the urine. So we have a large amount of dilute urine. And that's the definition, right? Large volumes dilute urine. Over 2 to 2.5 liters per 24 hours. Okay, again, it's super dilute, which means specific gravity will show that, as well as just looking at the urine. It's going to be nice and clear. Let's see through that. So there are 4 types, turns out, of diabetes insipidus, and they all present the exact same way. Polyuria, so lots of pee, hypotonic urine, so it's nice and clear and dilute, and polydipsia. These patients are thirsty, right? They're peeing out a lot of urine, and the osmoreceptors are triggered, and so they're triggered to they're thirsty, okay? So we have central, nephrogenic, primary polydipsia. Primary polydipsia is from like hazing, where the person is actually intentionally drinking excess water, so hazing, or maybe they have a sight condition, obsessive compulsive thing where they want to drink water, and then gestational. However, in endo, I only care about 2. So, and the 2 I care about are central or neurogenic diabetes, and nephrogenic. Okay, so let's look at each one. So this one, the name makes it nice and easy to remember. So again, we're dealing with a deficiency of ADH. The problem is in central neurogenic. The problem is in the posterior pituitary, okay? For whatever reason, there's abnormal synthesis and secretion. So again, central is the pituitary is the problem. And you can see there's various etiologies, and these all make sense to me, right? If you had a pituitary surgery, of course, this makes sense. Maybe you had trauma, TBI, or some kind of infection that messes the hypothalamus and the pituitary axis. You're going to have deficiency in ADH. Okay. Again, it's a synthesis problem. Where when we switch to nephrogenic, it's in the name as well, it's super easy. It's a renal issue, right? So it's insensitivity or resistance to ADH. So the pituitary is doing what it's supposed to be doing, and it's releasing ADH, but through the bloodstream, and it gets down to the kidney and that collecting duct, and it can't work. It's resistant to it. The main causes of this that you potentially would see are medications, lithium being a big one. Demicoclacine, so if you have somebody who's with SIEDH and they're on demicoclacine, it can obviously work too well and cause nephrogenic diabetes insipidus. Right? Most of the time, these are caused by the genetic kidney disorders that I purposely don't list because we're not in GU. Take home on these is just being able to identify if it's central or nephrogenic. And a lot of times a good history can tell you that, and then labs will tell you too. Signs and symptoms, again, whether it's central or nephrogenic, they're going to present the same. Polydipsia, especially ice water. They seem to like that. Polyuria, again, they have to have an excess over 2 to 2.5 liters per day, and that urine has to be dilute, right? It's not like infectious. It's not spilling blood or protein. It's just dilute. And a lot of times, if you're drinking a lot of water throughout the day, you're going to end up peeing a lot at night. So a lot of times they'll come in complaining because of the nocturia, right? Waking up multiple times a night to pee, that's a problem when it interrupts sleep. Or they could have enuresis based on this as well. Any questions about that? This one's pretty straightforward. And then again, take home is they're going to have if they're conscious, they're going to have normal serum sodium. But what I mean by that is, so you have you don't have enough ADH, and your body is just excreting all this urine. Well, the body's like, I need to reabsorb water, but the kidneys aren't doing it enough. So then it triggers the osmoreceptors to trigger the thirst response. So it's pretty cool. The patient is kind of treating itself, right? So that increase in thirst is helping maintain homeostasis. And it's not perfect, right? Because nobody wants to pee 5 or 6 times a night, but they feel okay, and their sodium, if they're conscious and able to drink a lot of water, their sodium is usually okay. So they're maintaining this homeostasis. However, that changes if the patient can't drink water. So maybe they don't have access to water because of a long flight or something, or they're deployed somewhere and they don't have a lot of water, or they're unconscious, right? That's probably the big thing. So if they're on a ventilator or something like that, and they're unconscious and they can't drink water, then you're going to have problems. That's where you're going to see the shift in sodium, and they're going to be hyperinatemic because they're unable to compensate and dilute themselves. Okay, you're like a marathon runner. That would be a good reason for them to get dehydrated. Any questions on that, guys? All right, so the workup, the same as before. We're going to ask about urine. We're going to just thirst detect that matters, and we're going to do labs specifically looking at their sodium and their urine. Again, history and physical exam can help pinpoint you, but you still need to do labs. The big thing with endo, and you'll catch on, especially after tomorrow, is you get a good history, a good physical exam. You think it's diabetes, and what do you do next? It's always almost labs, if they're stable. Okay. All right, so for labs for DI, we need a 24-hour urine collection because that's the only way we're going to make sure that volume is over 2 liters. This range is 2.5, but it needs to be over 2 liters. If they only have 1.5 liters in 24 hours, then they don't have diabetes insipidus, okay? And then the 24-hour urine collection, I know it's annoying, but it also will assess for osmolality and confirm that it's really dilute. You can order a plasma vasopressin for these patients. And usually for them, it's going to be low in central, right? Because central, the synthesis is the issue, the pituitary is the issue. So it's going to be low. And then it's typically normal in nephrogenic because, again, pituitary is working. It's the kidneys are the problem. Plasma osmolality is increased in both central and nephrogenic. So if you do labs and all you have so far is a 24-hour urine and a plasma osmolality, you've confirmed they have diabetes insipidus, but you don't know if it's central or nephrogenic. And we're going to talk about the one lab that helps confirm the difference of the two. Obviously, we're going to do additional labs and we'll rule out infection, check electrolytes, and the uric acid. So don't need to memorize that, okay? So the test that helps you determine is it nephrogenic or central is a vasopressin challenge test. Okay, so stay with me on these lovely endo lab tests. Okay, so for this one, you're not doing it in clinic, they're admitted and observed, and you're going to give the patient desmopressin, which is essentially ADH. So you're going to give them ADH because remember in DI, they have low ADH. And then you're going to measure what happens. Obviously, you're doing baseline labs, and this person's peeing a lot, and you have the super dilute urine. You give them the ADH, the desmopressin, and you see what happens. And that result will tell you exactly if it's central or nephrogenic. And so, again, if it's central, their thirst is going to decrease. Their urine output is going to decrease. Why? It's because, you gave them what they were missing, right? The pituitary is the problem. They didn't have enough ADH synthesis. You gave them what they're missing, so you're going to see a change. On the opposite end with nephrogenic, the pituitary gland works just fine. You're giving them ADH. Well, cool, my body is already making ADH. And the issue is the kidneys are resistant to it, right? They're not responding to it. So people with nephrogenic will have no response after, okay? No change. Any questions on that? Try to keep it really simple. If you have questions later, let me know. Imaging, so you want to do an MRI in these patients. So it's labs first, then imaging, and what you want to look at is the MRI. So again, I'm not going to read an MRI, but the posterior pituitary, it has this like kind of bright spot, which indicates that it's functioning. So people with central DI, you might not see that bright spot, and that might be normal for nephrogenic. But honestly, this vasopressin challenge test is more important. I'm not getting this MRI for a test. Okay, this is what I care about more. Understand this. Okay. Differential. Okay, let's go straight to treatment. So treatment for central diabetes insipidus. So for mild cases, you can just have them keep doing what they're doing, drinking water, right? If it's not interfering with function, they don't have to do anything. But again, if they're coming to see you, it probably means that it is interfering with function, right? So maybe you have a patient who's peeing 5 or 6 times a night, and they really like their sleep. Like me, sleep is really important. And so for those patients, you're going to give them what they're missing, and you're going to give them desmopressin, okay? Which is essentially ADH. There's different methods. You can do intranasal, oral options, and things like that for this. The big thing when you treat somebody with desmopressin is you want to start at the lowest dose possible. So the directions are usually twice a day, but what I do is I would just give them once a day at night and see how they do, and then gradually increase. And then, of course, anytime you're giving something that potentially can disrupt electrolyte balance and water balance, you want to monitor their electrolytes, right? So you don't want to treat the DI and give them SIADH, okay? And then regardless of if you treat them with meds or if they treat just with water intake alone, you have to counsel your patient on dehydration, right? So that's exercise, obviously, like long distance runners, those crazy CrossFitters. You really want to educate them on hydration. And if you get a GI bug and you're grown up and you have diarrhea, you're going to get dehydrated. So they definitely want to be aware of what to do in those cases, which makes sense. Nephrogenic, you want to treat the underlying cause for sure. So typically, I mentioned there's like different genetic renal diseases, which we're not going to talk about. But if it's a medication like lithium, you want to potentially stop that. Now, if someone's on lithium, they probably can't just stop it, right? And so you want to send them to their specialist. But interesting enough, diuretics, when you think of a diuretic like thiazide, you think of it makes you pee, right? It makes you pee. But weirdly enough, if you give them a thiazide, somebody with nephrogenic DI that's resistant to ADH in the collecting ducts, if you give them a diuretic, it actually helps treat them. And the reason is because the thiazide works, it increases proximal sodium and water absorption, so it diminishes the water delivery to the ADH area, the collecting ducts, and so ultimately reduces urine output. I know it's weird. You don't need to memorize it, but there you go. Indomethacin is also an option. All you need to know for this slide really is you're going to refer. and then know that you can give thiazide or indomethacin if you want. But honestly, you're not managing it. You're referring, okay? While you're waiting for that referral, you want them to obviously keep in that water intake up too. Okay, prognosis, people do pretty well. As long as they don't have any trauma to their thirst center, it doesn't reduce life expectancy, and then desmopressin is amazing and it can allow them to have normal function and activity for those people with central DI. Obviously, nephrogenic varies on the cause, but central not so much. All right, so we have, since we started 5 minutes late, if you guys are, we can go through the clinical correlation. For this part, it does involve participation, and this ends lesson 2. If I knew the AC was working, I'd push this till tomorrow, but if you guys are game for another 10 minutes, we can just knock this out. Yay or nay? Yay, I got some pluses. Okay, we're gonna push. I like it. I don't know about that. So last semester, most of the time I taught at like 1500. My schedule sucked, so we pushed a lot so that we could get 10 back graders. But again, majority usually rules, but I can't get majority, so we're just gonna go. Okay, so clinical correlation. When we're in person, this is going to involve obviously participation. For virtually, just write in the public chat. Okay, so. All right, so 55-year-old male with a history of recent radiation treatment for metastatic small cell breast cancer complains of nausea and malaise. What stands out for this person? You're riding closer to it. What is suspicious? Yeah, multiple users typing. I like it. Small cell, yes. Lung cancer, yes, exactly. But he doesn't feel good. That's never good. And radiation, that's not fun either. Right? Okay. All right, let's keep going. He states he has gained 5 pounds over the past 3 days, but denies any edema. He admits that his urine output appears darker. His urine appears darker lately. And we look at his meds, and he's on morphine and prednisone. All right, any additional thoughts? I'll go ahead and say the darker urine for sure, but what about those meds? What are we concerned about those meds? In a situation with small cell lung cancer and dark urine. Yes, SIADH for sure we're worried about. And the big thing with SIADH, yeah, immune suppression for sure, is opioids. Opioids can also, so we have 2 etiologies in this story. We have somebody with the small cell lung cancer can cause SIADH. Opioids can also cause inappropriate ADH. And then we have the dark urine. So multiple things point to SIADH. You guys are smart. All right, so Nathan Light's we do his physical exam. His blood pressure is fine, heart rate 90, respiration, I'm not concerned. His cardiac and lung exam is unremarkable. No edema, regular rhythm, all that good stuff. We do initial labs, and we do a UA, and the specific gravity is 1.035. And since we're not in person, everything's all yell, is that high or low? Do you guys think it's high? Okay, so from this, be thinking, what's the problem list for this person? Not the diagnosis. I know you guys are thinking SIADH already, but what is this guy's problem list? He had cancer, and he talked about that. He's obviously here because he doesn't feel good, right? And then, yes, the weight gain. Perfect. All right, so we have weight gain, fluid retention potentially, right? Because he's gained weight. There's no edema, cancer, nausea, malaise. Okay, moving on. What is the next step for Nathan Light? So we're in Indo. We have a UA and a good physical and a good exam or good history. What should we do next in Indo? Labs, yes, it's always labs. When in doubt, look at the labs. Okay. All right, so we get CMP, and his sodium is low. Creatinine is fine. Plasma osmolality is also low, right? That indicates dilution, and a high urine osmolality, which again, that's specific gravity plus the urine osmolality says we have concentrated urine and low sodium. Diagnosis, there are only two things it could be. We've already said it, so I'm just going to push. It's SIADH, secondary to what is the etiology? What is causing this inappropriate ADH release in the body? Cancer, correct. Cancer and those opioids probably aren't helping anyway, but yes, small cell lung cancer. So what do we want to do for this guy? So well, he's stable, right? His vitals are stable, and he's not hypertension. His labs are mildly low. Yeah, fluid restriction first, okay, and educate him. And also, what are we doing about the small cell cancer? Oncology, but we're going to monitor this guy closely, okay? All right, 3 days later, his wife, he comes back in. His wife says he's vomiting, he's disoriented to time and place, and he has a severe headache. And his sodium was 130, and now it's 123. All right, are we concerned? Yeah, we're concerned. We don't like this. What's your assessment? Yeah, SIADH with worsening hyponatremia, and so what do we do to treat it? Yeah, we want to watch for that osmotic demyelination. So we want to treat with the hypertonic 3% saline. How do we treat it? Super fast? Yes, slowly. Perfect. So I'm trying to read stuff out loud for the recording too. Okay, so yes, so we want to do IV hypertonic saline, but not too fast because we want to prevent that locked-in syndrome, that osmotic demyelination. So once we get him stable, we as in the ER gets him stable, then we would maybe consider some additional medications, those Bactins, the Lasix, or the demeclocycline. Okay, but again, focus on getting him stable and the rest. All right, good case. All right, moving on. One more case, Tinkerbell. I swear these cases go faster in person, guys, so thank you for participating. Okay, Tinkerbell. She's a 40-year-old female, 10 hours, status post, a transphenoidal resection. Just ignore that. So she had a transphenoidal resection of a macroadenoma. So she had a pituitary adenoma, and it was removed, okay? She is complaining of insomnia due to thirst and nocturia. She also reports she's urinating more than she has ever before. What are our initial thoughts? DI, yes. DI, yes. Post-op nocturia, polydipsia, urea, yes. If you had to guess, I have no labs, but if you had to guess, central, yes, central over nephrogenic, just based on her history. Great job. So again, I promise I will keep this simple in the exams too. All right, so we did vitals on this person, and her blood pressure is 110 over 76. Now, for me, that's totally fine, but we want to make sure this might be hypotensive for her, right? Some people that's normal, and some people it's not. So we look at previous vitals to see, but let's go ahead and say we're a little concerned about some hypotension. Heart rate is slightly elevated, but otherwise vitals are normal. Under a markable exam, what should be the next step? So we did a really good exam. Yeah, so I see specific, yeah, so we want to do labs. We see vasopressin test. What other labs would we do? Because that vasopressin test, remember that one's like an inpatient one. So what can we do right now? Yes, urine. What else can we do? What blood test should we check? Yes, BMP, CMP. Perfect osmolality. Great job. We can also check ADH vasopressin directly if we want. You guys are, all those answers are right. So next thing, labs. So CMPUA 24-hour urine. And again, that 24-hour urine is because we did confirm that it really is excess, right? It really is over 2 liters in a day, and that they are dilute. Man, I updated this slide, but it didn't show up. So let's just say the BUN is normal. I do send you these slides after I teach, and this will be corrected. But we'll say glucose is normal, BUN is normal, sodium is normal, and 144, high normal, but it's normal. Calcium, potassium, everything's normal. You look at the urine specific gravity, and it's low, and the urine output is high. Okay, so again, just confirming, so we're still thinking DI, right? Everybody's still thinking DI. Thumbs up. Okay, what is the list of problems? I'm going to just tell you guys. Okay, so high urine output, low specific gravity. I'm going to say BUN is fine. Normal sodium, right? So the sodium, we'll look at it. Yep, it's normal, thankfully, but she has insomnia because of her thirst and urination. So what's our diagnosis? For sure, diabetes insipidus, right? We're thinking central. How do you what lab do you use to be sure it's diabetes? Yes, vasopressin. Perfect. Vasopressin. We think it's central for sure, but we would do this test. And again, we think it's central because that history of the pituitary surgery. But again, to confirm, we would have that. So if we do the vasopressin, are we expecting a response or no response? It's like simply. So if we give it is yes, perfect, a response, yes. And let me show you what that looks like in the slide. So we monitor labs and we see a change, decrease in urine volume, decrease in thirst, the specific gravity and osmolality increases and it changes, right? From that super dilute, it's more concentrated. If it was nephrogenic, we would see no change. Perfect. So central DI, secondary pituitary surgery. Anybody want to guess on treatment? Now remember, Tinkerbell came in because she is unhappy. She is peeing and she is not sleeping. So we can do nothing or we can use medication. What do you guys want to do? Yes, desmopressin. Let's give her what she's missing. Post-op pituitary surgery, and that post-op, it might correct itself. That's not for us to decide as primary care providers. We can give them desmopressin spray. Again, I would do it at night, but we're essentially replacing what they're missing. All right, y'all, that's all I got. Thank you for bearing with me, especially for the clinical lab section. Tomorrow the only lesson you need is number 3, and we will start with some check on learning, so some multiple choice questions. My fingers crossed it's in person, but if not, I will adjust and make this work. I will hang out here for questions, or again, please text me if that is what you'd rather do instead, okay? Good luck with farm and MPH because it's the longest day ever today. Good luck.